Okay. Good morning, everybody. Today, Dr. Patel and I will be presenting a case of a patient with a cellular lesion that was managed by Dr. Chichon and Dr. Donaldson. I want to first start by taking the time to acknowledge all the members of the multidisciplinary team that took care of this patient. Dr. Chichana from the neurosurgery department, Dr. Donaldson from ENT, Dr. Sampson from endocrinology, Dr. Genta from pathology, and Dr. Vibute from radiology.
Okay, so this is a 68-year-old female. She had a history of type 2 diabetes, hypertension, and thyroidectomy for nodules and osteopenia. And she was referred to her outside endocrinologist for bilateral adrenal nodules. This was incidentally found I think she had abdominal pain, and they did imaging for that, and it was found incidentally. So then she had a workup for adrenal nodules. She said, though, that she started having symptoms that started about 1.5 years ago. Otherwise, she didn't really complain much, even during all of this. She said that she was having weakness in her arms and legs, significant fatigue, flushing in her cheeks, maybe some tanning of her skin, and she was having a lot more easy bruising. But it was really the weakness in her legs and her arms and the fatigue that was probably the most troublesome to her. She had her last steroid injection 9 months prior to her workup, and she wasn't taking like exogenous steroids at all. We can go to the next slide. Her BMI was 30.47. She had some slight androgenic alopecia, flushing on her cheeks. She had a dorsal cervical fat pad and supraclavicular fullness as well on exam. She didn't have any abdominal striae, but she did have like a protuberant abdomen, and there were no thinner extremities that we would normally see with like Cushing's, but as compared to like the abdomen, where it was kind of all over. She was overweight, but she did have significant proximal muscle weakness. She wasn't able to do a deep squat without assistance at all, and she would like fall over. Actually, she looked very mild in her exam for Cushing's, but the suspicion was obviously still there. And then we can move to the next slide. So this was her CT. If you look kind of right by the liver, there are one of the adrenal glands, and then the other one's like right on the opposite side. They're pretty thick and nodular. They should be actually very thin, kind of like Y-shaped, thin, long adrenal, like little lines, but these are nodular and bumpy in nature. The Hounsfield units were less than 10, so making them more consistent with like an adenoma or adenomas in that area. And I think the largest size was documented at 1.5 centimeter. We can keep going. So we did a hyperfunctioning workup for the adrenal nodules, and obviously the suspicion was highest for Cushing's. And looking at her labs, her AM cortisol was 21 and her ACTH was 85. So that was already kind of a red flag as to maybe she has bilateral adrenal thickening because of ACTH stimulation. And so she had a DHEAS, it was 64. We did a renin and aldosterone to make sure that there was no hyperaldosteronism, and which there wasn't at all. When we see adrenal nodules, that would be one of the things that we work up. And we did get a PM cortisol as well to check for whether she's lost any diurnal rhythm, and it was 15, so it wasn't low, it was actually a little bit higher. And she had 2 late night salivary cortisols. Those were done on the outside, but they were both elevated. I should have made those red. Sorry about that. Well, all of these red I should have done, but 0.162 was elevated, and she did it the proper way. And she had a dex suppression that she failed, as well as 4.2, and her 24-hour urine she failed. So the suspicion was for ACTH dependent Cushing's. She didn't fit like the normal phenotype of like a younger woman, but so initially when I saw her, I was very concerned about an ectopic source, but we ended up doing, of course, she had MRIs, which Lena will go into in a second.
When the patient consulted, she had a previous MRI that was conducted at another facility. Initially, the report from that facility did not indicate the presence of any pituitary adenoma, but an overread by radiology here at Mayo Clinic indicated that there might be a lesion located to the right side of the pituitary gland. So because of this, a repeat MRI was ordered, which you can see right here to the right side in this T2 coronal sequence, which gave the impression of a left-sided fullness. And because of these two discrepancies, the patient underwent inferior petrosal sinus sampling.
So these are the results of her IPSS. So initially she started off at baseline with the right as compared to like the peripheral looking like a central source. So it looked like the ratio was like 3 to 4 to 1 as compared to the periphery. And then she did get DDAVP to stimulate, and instead of going up like significantly in both of them, both the right side and the left side, the right side did something very strange where it went like 170s, 120s, and then it started going down and then going back up. And at one point at like the 2 minute mark, the left side was more so than the right side as well. This was kind of a very strange result. And I'd talked to Dr. Sampson and one of the other endocrinologists here, just because I had never seen a result like this. And generally, we would say it'd be a positive test if it was 3 to 1, like if the ratio was 3 to 1 for it being a central source, so from the pituitary rather than from an ectopic source. And because it was with DDAVP and all of the data is really with CRH, and all of the experience that I think everyone has had so far has been with CRH, we weren't sure if maybe she just didn't stimulate to really high amounts, like in the several hundreds, like over like mid 400s, 500s, because we're using DDAVP and maybe these are the type of numbers we would expect. So we weren't really sure given this kind of mixed data type of IPSS. So we did decide to look for other sources because low grade pituitary, low grade like carcinoid or neuroendocrine tumors can have like can have similar patterns to to a central source of Cushing's as well. So we were just looking for other sources, like an ectopic source, just given that the IPSS results.
Can I make a comment?
Yeah, please.
Like for the trainees who haven't seen a lot of IPSSs, often you'll see levels of 2,000, 3,000 next to the gland. And so that was one of the issues. So in spite of this greater than 2 to 1 ratio at baseline, which actually supported a right-sided lesion, and at the time the MRI was read as left. And as Dr. Shulis points out, we don't have as much experience with DDAVP, and I'm not even clear if they have vasopressin receptors on some ectopic tumors, so I'm not quite sure about that either. The other point is when you do IPSS, the patient has to be hypercortisolemic at that time because the central source should be there or it's suppressed because it's peripheral. And if a patient is somewhat cyclical, if you look at her ACTH levels here in the periphery, we're seeing, 30, 40 versus the 85 she was seen on workup, and we can see ups and downs. So if you do IPSS at a time where the patient isn't like actually raging Cushing's, that can also be a red herring. But Dr. Shulis will tell you her next steps here.
Thank you, Dr. Sampson. So we did look for ectopic sources of ACTH production. We did a CT chest looking for bronchial tumors, like a low-grade bronchial tumor, because they can suppress with an 8 milligram dex the way the pituitary gland can, and the same with this patient situation. We also did a Dota Tate because the CT chest didn't show anything, CT abdomen didn't show anything. So then we did a Dota Tate scan as well. So Lena can go over that.
Yeah. Well, the Dota Tate, as Dr. Patel stated, was conducted in order to identify a possible ectopic source for the ACTH production. So neuroendocrine tumors express a high level of somatostatin receptors, and the Dota Tate is a radio-labeled somatostatin analog that can bind to them and then show them in the Dota Tate PET scan. In this case, there wasn't any ectopic focal source that could explain the Cushing's disease. Incidentally, however, it was discovered that the patient had a left periclinoid meningioma from this scan.
A second comment, can you stop on the pituitary gland there?
Yep.
Okay, so a little bit more. So one of the things about this read is it looked like, Selena, I think there's a point where it's very focal in the gland there. I don't know, it might be hard to grab it with your automated. There we go.
Okay.
So this was read as left-sided, so you can see that it kind of skews to the left. So we have an MRI read on the left. We have a possible increased uptake in the pituitary. Now the pituitary is going to light up because it has somatostatin receptors, but it looked asymmetrical. Then we have an IPSS with a baseline that looks like it's on the right. So this is why there was a lot of controversy about this case. What we ended up landing on in talking to radiology is that with the gland being pushed over to the left in the MRI, there was a thickening of the gland on that side. And so there could have been more signal from the Dota Tate there. And so we've got a bunch of results that seem to contradict each other with this patient.
Yeah. So we actually did, like Dr. Sampson said, I think our entire group talked about her, and then we talked to radiology as well. But during that time, I repeated her testing because I was like, well, let me just make sure that everything is still the same. So I think she actually probably has a cyclic nature to her, and that might have been why the IPSS was off. So she had another 2 milligram dex, and she suppressed this time to 1.1. She had a late night salivary, and it was less than 50. Her ACTH in the morning was kind of that 59, which was around what she was at her baseline for her IPSS. Cortisol was 12, DHEAS was 72, and her urine-free cortisol was 19. So she was cycling, it sounds like. And if we go to the next slide, so like Dr. Sampson was saying, we did review all of the data. We did also look back at the procedure note for the IPSS, and it sounded like the way that they described it, there was the majority of the venous drainage from the inferior petrosal sinus on the right side had like a very strange flow to it. It flowed into complex veins in the posterior right neck as opposed to directly into the right internal jugular vein. So this might have led to some of the discrepancy that we saw with the IPSS, or she wasn't actually fully like raging Cushing's, as Dr. Sampson said, might have been another contributing factor to it as well. Her baseline cortisol at the time in the afternoon was 17, but still doing a 24-hour urine cortisol retrospectively probably would have been the best idea on my part. We can go to the next slide.
Okay. After careful review of all the information mentioned, the repeat MRI was reviewed again with neuroradiology, and this time, the T2, T1 sequences weren't really helpful, but in the T2 coronal section, we can appreciate this hypo intensity in the right side of the pituitary gland that's abutting the right cavernous ICA, and that is pushing the normal pituitary gland towards the left and causing left deviation of the pituitary stalk. I know Dr. Vivute is online. I don't know if you want to comment anymore, Dr. Vivute.
Not really. You had excellent discussion so far, but this is a classic example how these ACTH secreting adenomas can be difficult to identify on MRI. About 30 to 40% of these adenomas are incorrectly identified on MRI, actually, if you look at the literature. And this is a classic example of that. But what is, to me, what I take away point for me was, at least, when the infundibulum is shifted to the other side, the adenoma should not be on the same side. So even though the gland looks plump and prominent on the left, since the very fact that the infundibulum is pushed away from the midline towards the plump side, you have to think twice and look at carefully. And this is an example where we can actually see that the adenoma is almost blending with the gland, is slightly hypointense compared to the rest of the gland. And the T1 weighted sequence is not really helpful. What they have found now is that actually, we do these are not 3D T1 weighted sequence, but if you do a 3D sequence, like a SPGR sequence, which you obtain for surgical planning, they tend to show more lesions compared to this classic coronal T1 weighted sequence. So henceforth, if you have a suspected case of ACTH adenoma where you didn't see the lesion in the primary MR, then it'll be a good idea to get the patient back and do a thin, high resolution 3D weighted sequence. And now also be careful that these 3D weighted sequence can actually lead to false positive diagnosis also, but that's a better sequence than the T1 which we see here in the current exam. Yeah, that's all I have to say. Thank you.
Thank
Dr.
you,
Vibuda,
Dr.
just a quick question. Do you know why they didn't use CRH for the IPSS?
It's
I do not know. Yeah.
it's not being made right now.
It's not going to be made ever. So
Oh.
as with a lot of our very important stimulatory hormones that we use rarely, the companies that manufacture them don't see the value. So we do not have availability of CRH anymore in this country.
Oh, I see.
Exactly.
Oh.
Yeah, so there you know, there's a lot of there is a lot of literature that validates the use of the current medications. But it's not ideal, but it's unfortunately what we're stuck with.
Right. Just to complete the imaging, I want to highlight that there's also a hyper intense part of the tumor, which most likely is the cystic component. And because the patient was opted to go for surgery, preoperative CT was performed, which did not evidence any sinusitis. The septum was midline, and the venous sinus was well aerated.
So, Lena, I guess while you're playing that, my plan going in was to address that right-sided area. Hopefully that was the lesion. The goal, if I didn't find that, was to explore the left side, but I'm not a big fan of exploring the gland just because obviously the gland is quite small and it's very difficult to find a lesion within the gland when you're working in with a small area. So our plan was to address the right side, and then if we didn't find anything, do the left side.
Okay, so the diagnosis was a pituitary the differential diagnosis included a pituitary microadenoma, Cushing's disease. And like I said before, the patient opted to undergo surgery. And
part of the differential is not tumor, so.
So because the patient was symptomatic and because there was microadenoma evident on the right side of the MRI as a possible source of the hypercortisolism, an endoscopic endonasal transsphenoidal approach was decided to resect the tumor. Dr. Chechana, unfortunately, we do not have the video, but Dr. Chechana, would you like to comment on the surgery?
Yeah, so we just did our standard approach, transsphenoidal with Dr. Donaldson. We exposed the gland, tried to expose the sella from medial cavernous to medial cavernous. We did not open across the cavernous sinus. And we just basically opened the dura and addressed the right side. I did this case with Dr. Almeida, and we did find a lesion on the right side, and we removed it in block, just saying extracapsular because it was made easy because it was so small. Yeah, it went pretty routinely, like all the other pituitary cases we do.
The patient was transferred to the ICU for postoperative management. The nasal packing was removed from postoperative day 1, and she was discharged on postoperative day 1. And because it was such a small lesion, the postoperative MRI scan wouldn't really be helpful to identify any residual, if any, was left, and even with dedicated pituitary sequences. Dr. Vibuda, do you have anything else you would want to comment on that?
So actually, before Dr. Vibuda, we did it in a wrong order on this. It should have been a pituitary sequence MRI, but it was a normal brain MRI. But because the hormone levels were what we wanted, we didn't repeat an MRI image.
Okay.
And typically I wouldn't get an MRI scan, but I was unsure about the pathology, so we just got one just to make sure that area was cleaned out as a baseline.
Okay. Just next, here we have H&E staining, which demonstrates a very homogeneous cell population with stippled chromatin, and then we can see that there's not really heterogeneity in regards to the nuclear size, and they're well-rounded nuclei, suggestive of an adenoma. And then in immunohistochemistry, we can see that the tissue is positive for the transcription factor TPIT, which is characterized with corticotroph type adenomas, and it was positive for ACTH as well, also coinciding with a corticotroph type adenoma.
So the diagnosis was, as Lena said, a pituitary adenoma is corticotroph type, and she likely had cyclic Cushing's. And so when we look at the post-hospital course, we can go to the next slide. So she, like we said, was discharged post-op day 1. Her cortisol while she was in the hospital dropped to 3.5, and she didn't need any, she didn't have any DI. She didn't have any SIADH either. She was fluid restricted like we would normally do. And her ACTH a week later, she was feeling like very stressed. She had like more shortness of breath than usual, and her ACTH was 43 and her cortisol was 20. So at the time it was pretty elevated, and then we still had her on hydrocortisone after surgery. We had her initially on dexamethasone, then transitioned her to hydrocortisone. And so we did cut back on the hydrocortisone, and her cortisol just came back yesterday as well. And it was in the 8s, which is expected. So she's, you know, having at least a little bit of her levels are a lot lower than they were before, even a little adrenally insufficient as compared to previously. So she's overall done pretty well.
Can I make a couple comments about that?
Yes, please.
Okay. So I learned about DEX from my neurosurgery colleagues with Cushing's because it's very smooth and potent. And in that first week post-operatively, the drop in cortisol can make patients very uncomfortable. And I find that they do a lot better just on a week of DEX. The second point is knowing what you know now, seeing the pre-op labs where she was hypercortisolemic, then you retest her and she's not. Her IPSS looks cyclical. It is completely possible that her entire corticotroph population in her normal pit was not fully suppressed because of the cyclicity of her disease. And so when we expect a cortisol and ACTH drop post-operatively, we expect that because the gland is fully suppressed. But what you're seeing here could just be that her own corticotrophs aren't as suppressed as they would be in someone with constant Cushing. So it is, I'm not concerned, and especially knowing the pathology now and seeing that post-op day 1 drop.
And Dr. Sampson, if I may, how often do you see this cyclic Cushing?
You know, it is actually much more common than we think it is. I would say probably, this is the reason we have to do 3 urine-free cortisols on patients. You know, one or two will come back positive, the third will be normal, 3 salivary cortisols. So we do see this a lot. And I don't know whether it's a waxing and waning of the ACTH with minor suppressibility from cortisol, and then the cortisol, the ACTH drops, and then you start the cycle all over again. And cycles can be within a day, within a month, within a few months. It's a very interesting phenomenon.
So is it something you always keep in the back of your mind if the hormones don't seem to point out? Thank you.
Absolutely.
And how long the cycle lasts? Like if the levels are normal, and you're still suspecting adenoma, you're still suspecting central source of Cushing's, then would you, how frequently or at what interval would you repeat the labs?
It's a great question, and the cycles vary very differently between patients. What I will try to tease out, if there's some cyclicity to their symptoms. So do they have days when their legs swell? Do they have days when their face is more flushed? Do they have days when they have heightened anxiety or insomnia? And I'll send them home with salivary cortisol kits and say, I want you to test on those days, and also test on a day when you don't feel those symptoms. And sometimes we'll be able to catch the cyclicity of the disease if we tease out the symptoms.
Thank you.
As the last slide, we have here an article as published by a group over at Mass General, titled Transsphenoidal Surgery for Cushing's Disease After Non-Diagnostic Inferior Petrosal Sinus Sampling. The objective of the article was to define what was the adequate course after a negative IPSS in patients that did not have an ectopic source of Cushing's disease. And what they found is, after reviewing 288 IPSS procedures in 283 patients over a 20-year period, 44 were non-diagnostic, and of these 44, all went exploratory TSA, and 42 of them, 95% of them, had a pituitary source that was surgically proven and resected with a remission rate of 83%. Thank you.
That's a pretty cool study there, Susan. That means that makes an argument for us that even if if the IPSS is not conclusive, but there's the only question is whether or not in those 280 plus patients on the Mass General, was there something in the MRI that pointed them, to go into the OR and to lean and explore in one side of the pituitary more than the other. The way that I learned all the way back when I was with Dr. Wilson, he used to do these vertical cuts because back then, they did a lot of exploratory surgery because the imaging was not as high quality as we have today. So that's the only thing that I just don't know. At Hopkins, we had a protocol. It was a pituitary protocol, very heavy duty, and I think Prasanna and Vivek had done a beautiful job also getting a high quality. And in this case, I just don't know whether or not the 7 Tesla in the future will be a great utility for some of these cases. I have no experience yet. Maybe Prasanna can comment, or you, Susan. I don't know if you had any experience with the 7 Tesla and the literature.
Yeah, this is an excellent question, actually. 70 has a lot of promise. The only thing is that we have to be really cautious about this because the skull base causes a lot of susceptibility effects. And, we had some, we have some success in getting good images through the Stella, and we are working on it right now. But what the biggest hurdle we seem to have is obviously the susceptibility artifact from the skull base. And if you're seeing the epilepsy studies which are done on 70, you'll realize how much susceptibility it generates along the skull base. But there is literature out there which says that 70 is definitely better because of high SNR. And we are working on those sequences as of now.
I do know that Dr. Zada at Keck School of Medicine has looked at this in occult tumors in their Cushing's patients and then used their 7 Tesla and found lesions in a higher proportion. Dr. Gronell in England is actually pioneering methionine PET imaging, which can pull out a functional Cushing's microadenoma when it is not visible at all on MRI. So that will be another future advance in radiology for these types of patients.
Beautiful, great case, and great opportunity for us to explore some new imaging modalities as we're having more and more of those cases. So good. So to conclude, this patient did well and everything went well. And I think that is in remission, Susan. Is that what I gathered at the end? Are you happy with the outcome?
Well, I do think that there's a cyclicity to her, and I do think she's cured. We have the pathology, and we'll have to keep a close eye on her and probably do a dex suppression test and a few salivary cortisol.
Good.
Yeah, from radiology perspective, I feel henceforth, if you have a patient with central Cushing's, then it'll be a good idea to think about the 3D sequence, 3D SPGR sequence post-contrast, and possibly a 7T.
Beautiful. And I see the paper that you mentioned right there, Susan, that you put in the chat for European Journal of Endocrinology. Maybe in the future, we can put a couple of slides for our next month, just a couple of little things right there to teach, just like what Lina did with this first case, the Mass Gen.